talk about some hormones that the kidneys are affected by that cause more sodium reabsorption, and that will increase blood volume, and that will increase venous return, okay? Just drinking fluid doesn't necessarily do that but over the long term, but over the short term it does. So venous return stretches the heart wall, which causes the muscles to contract more. That's preload. All right, the second factor up there is contractility. It's like, well, we're already talking about contractility. What I'm talking about here is calcium ions, okay? So, remember that diagram I showed you with norepinephrine and the calcium ions? How does having more calcium ions increase contractility? We talked about this a little bit on Thursday night. Think back to your skeletal muscles. Yeah.
Attaches to more binding sites to free.
Close. It attaches to troponin. That moves, tropomyosin moves, and then, yes, we have more binding sites. So as a result of more calcium ions in the cell, there are more places on actin that myosin can bind to. More myosin pulling on the actin increases the force. If we have a tug of war, and you add 5 more people to each side of the rope, the tension is going to be greater, okay? So if we look back to this earlier diagram, I think I had it in here. No, I didn't. It was from last Thursday. So we look back at the diagram that showed the effect of, I don't have it in here. It showed the effect of norepinephrine, and we look at calcium is going to bind to troponin, and troponin is going to move aside once it has calcium on it, and tropomyosin moves down into the groove between the twisted actin, and that exposes more binding sites. So we have myosin pulling on the actin. If we add twice as many myosin heads pulling on the actin, that's going to create a greater force, all right? So anything that adds more calcium to the cell is going to increase the force of contraction, all right? That's represented by this diagram. Normal end diastolic volume, so we don't have an increased venous return here like we do here, but normal end diastolic volume with greater amount of calcium available to the actin and myosin means the fibers are going to contract harder, and we're going to move more blood out of the ventricles. Okay? So without adding any additional volume to our end diastolic volume, we're going to have a larger stroke volume, less blood left in the heart for end diastolic volume, and cardiac output will go up if we increase just the stroke volume and have a normal heart rate.
So the third one is
The third one is calcium.
Okay.
So the first one is normal. This is showing the effect of the Frank-Starling law where we increase venous return. This is showing a normal venous return, but the addition of calcium and a greater force of contraction, resulting in a lower end systolic volume. And this one is showing both. Showing both the increase, but we're not coming back to normal. We're getting a lower end systolic volume. So it's showing both the Frank-Starling law effect and the calcium effect for that last block. So you have the first, the third, and the fourth on your current lecture notes. This is the one I added because I wanted to differentiate this from the venous return all by itself. All right, the last one we're going to talk about, and then we'll look at effects of ions and chemicals after you've had a chance to look at the PhysioX over the weekend, is the afterload. There we go, afterload. So a preload is how much blood comes into the ventricle before it contracts. What do you think afterload is? It's what it has to work against. All right? So if someone has hypertension, either pulmonary or systemic, high blood pressure. When the ventricles contract, there's already increased pressure in the vessels, and the heart has to push against it. It's like you know, everybody has their own way they fear dying, and I've always, okay, what would I do if my car went out the levee and into the river? And I go through, okay, I do this and this and this and this. And you're supposed to let water come into the car. Seems totally against the, you're supposed to let water come into the car, find the highest place where the air is gonna get trapped and let water come in, because you can't open the door against the greater force of pressure. So you have to let the water pressures balance on either side. Good to know. All these hints I give you. If you're gonna get stabbed in the neck, then you wonder if we'll get to the rest of it. So you have to roll the window down if you're underwater to allow, or break it or whatever, to allow water to come in so that the pressure forces are balanced. So you can't push that door against the river. So I don't know what you do if the car's tumbling in the river, but anyway. So if there is high blood pressure, you have hypertension, you have a blood pressure of 250 over 110, then when the heart pumps, it has to pump this pressure against what's already in the aorta. And it has to move that blood out before it can move any more blood. So that back pressure from hypertension is resisting any more blood going into that space. Okay, it's like trying to blow up a balloon that already is full of air. It won't stretch much farther. Also, we talked about mitral stenosis. So if the AV valve doesn't close very well, all right, and the blood is pumping up against blood that's already in there, it's going to be difficult to move blood out. So the force is going that way instead of going into the aorta. So having an atrioventricular irregularity or having hypertension can cause an increase in preload, which decreases the amount of stroke volume that can occur. Okay? The other two is going to increase it. So increasing preload, increasing contractility will increase stroke volume. Increasing afterload will decrease stroke volume. Okay? Does that make sense? You can't push blood out of the heart if there is an increase in what's pushing back. Okay? And that occurs with AV valve problems or with high blood pressure, either in the pulmonary trunk or in the aorta. All right. So we'll stop there. And let me just say a couple of words about the heart rate. Oh, we have one more question. So, an increase in end-diastolic volume would do what to end systolic volume? To increase your end diastolic volume, okay, what would happen to your end systolic volume? And we're talking about preload here. I didn't say anything about contractility. Increasing so if we increase end diastolic volume, which of these factors are we changing? You have to increase calcium ions for that. So all we're doing is increasing the end diastolic volume. So that's changing preload, right? End diastolic volume and preload are almost interchangeable. Okay, so we could change that question to, if we increase preload, how would that change in systolic volume? So which of these images? So here's our normal. So is that question asking about this one or this one? Okay. So increasing end diastolic volume would cause what to happen to end systolic volume? Compare this first image to this second image.
It stays the same.
Okay? Now, what if the question said increasing end diastolic volume would do what to stroke volume? Then it would increase it. Yeah. The whole purpose of the Frank-Starling law is to allow us to increase end diastolic volume. Stroke volume increases, but we have the same end systolic volume. We have to increase contractility to get a decrease in systolic volume, okay? That's what I want you to get from that image there. Any questions on that concept? Okay, one is talking about what happens when we stretch the muscle cells. That's preload. Contractility is talking about what happens when we add extra calcium. And the muscle cells, from their normal position of stretch, contract even harder. Okay? All right. So as we look at the ECG, I want to come back to this image here. Now this is not a very long ECG strip, but it's easier than my diagramming it on the board. So when you look at the little machines that are over here, you will see them on these strips of paper that have these little squares, okay? Each little square is 1 millimeter in width and height. When you look at the strip, it's made in little boxes of 5, so 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, right? And then every 5 of those sets is 25, right? So the machine is set, and you can see that because when you look on the strip, there will be a little tick. Everywhere there's 25 little tiny squares. And the machine is set to a chart speed of 25 millimeters per second. So it takes it 1 second for the piece of paper to travel 25 of these little tiny millimeters. All right? Now, before I put this stuff online, I had students do the ECG, and then I asked them to staple it to their paper lab report to turn in, and I asked them to figure out heart rate, and then measure different components like the T wave or the QRS. So if you're going to measure heart rate, you're going to come along, and I'm doing this lazy. So if you measure 5 seconds, and you have 1, 2, 3, 4, I don't even know if this is going to come out right for a living person. How many 5-second intervals are there in a minute? 12. You're correct. So if you measure 5 seconds and you count 4 QRS waves, what do you need to multiply that to get your heart rate? By 12. So the heart rate would be 48, barely. Okay? That's not very accurate because you can measure it for 1 second and then, you're going to have changes beat to beat. So try to measure a strip that's 20 to 30 seconds long. So just divide whatever you're measuring into 60. That's how many seconds we have in a minute, in case you've forgotten. So if you count the number of heartbeats in 20 seconds, you're going to multiply it by 3. And if you count it for 30 seconds, you're going to multiply it by 2. And if you count it for 60 seconds, you don't have to multiply it at all, but that's going to be a pretty long strip, okay? All right, so that's for heart rate. Now, what if I want you to measure the time of the T wave? 25 millimeters per second. Here's your algebra, your ratio, folks. Not even true algebra. So it takes 1 second for the strip to travel 25 millimeters. How many millimeters long is my T wave? Let's start here. 1, 2, 3, 4 and a half. All right, so how do I convert distance to time? So my unknown is time. And I know my distance is 4.5 millimeters. You cross multiply and divide. 1 times 4.5 is 4.5. So you always take your distance and divide it by 25. Okay? So if my segment here is 1, 2, 3, 4, 5, 6, 7, then I would take 7 and divide by 25. Are we gonna get a fraction? Yes, because 1 second is from here to here. So any of these that I'm measuring are gonna be less than a second. So you've done it wrong if you get a number greater than 1, okay? Because no part of our ECG should be lasting longer than 1 second. The entire cycle would be about a second, okay? So whatever you're measuring, and I have you measure one component for the lab report. So you're gonna count how many bars, how many squares that event takes. So if it's the PR interval, you're gonna count from the P to the S there, all right? And then divide by 25. And that will be a fraction of a second. Now, the ECG machines are set up. The electrodes are 4, and the location that you are supposed to attach them to are written on here. So the electrodes are built in, we're not gonna feel and stick. It's written here, so this says RA, which would be your right arm. You're not putting it on your arm, you're putting it on your inside of your wrist. All right, so you wanna take that metal part and put it on the inside of your wrist. Okay? RL would be right leg. So remember where your medial malleolus is? That's the bump from your tibia, so put it just above that. Okay? So put it on your leg, right up there like that. Now, we have natural oils on our skin from sebaceous glands, which oil does not conduct electrical current. So there are alcohol swabs here, so make sure you clean off your skin. And then we have conduction jelly. So put that on the metal part of the electrode. And after you've cleaned your wrist, and then put that on your wrist or your leg, okay? The person, you don't need to run everybody in the group, although you're welcome to. It'd be nice to let another group in, and not just have run all 4 people before all other people are waiting. So they're both set up here. So you want them to be sitting in a chair and resting quietly. Some people, and the transmission depends on body composition, all right? So concentrations of salts and muscle tissue and adipose tissue and so on. So they're gonna look different. Some will be really noisy, lots of little movements, electrical part of the life framework. Some will be nice and clean and smooth. So it's just gonna vary. So once you have everybody clamped down, and they're resting quietly, then you're gonna push this green button right here, okay? And it'll start to run. And once you have it, about yay long, enough to get a good heart rate, then you can just tear it off, okay? And count the heart rate, and then you can kind of, if you want to cut it up into pieces, so each person can take one home and practice measuring the time components on it. So they're both set up. I'll put a trash can on each one, so you can put your trash from the paper towels for cleanup, as well as the alcohol swab. If you want to take a few minute break before you get started, or go ahead and get started.